Parvoius Cymru. Good morning and welcome to the meeting of the Board of Public Health Wales. Claire Jenkins of Dewey East Gadeirydd. I'm the Vice Chair of the Board, but obviously chairing today. So we've got apologies from Pippa Britton, the Chair, and Kate Young, one of our non-exec directors from the sector. We've got Liam Scott, who is attending online, and we've got people attending for item 3, Gary Shanker and Sophie Cousins. So before we get going, I just need to read out these words. So the meeting is being conducted entirely electronically and in this room. Can we ask everyone to speak up? We've had a few issues this morning with people not being able to hear online, so I'm probably the worst culprit. So we all need to project, and if you could say your name clearly before you speak each time. The meeting of the board is recorded via Microsoft Teams for the purpose of ensuring an accurate record of the minutes. The recording will be stored until the minutes are confirmed at the next meeting on the 30th of November, after which it will be deleted. Just before we go into Right, so let's go with declarations of interest. Any declarations of interest not previously noted? No, lovely. Just before we go any further then, I just want to hand over to Tracy for a minute because we've got an important thanks to say.
We have a deal there and welcome Zoe particularly. We just want to say before Zoe gives us, I know, an amazing presentation around all of the activities that we're doing to support people from a sexual health perspective. Just really conscious, Zoe, that you retired. You lucky thing, we all, at the end of October, and we just wanted to, on behalf of the board, to say a very, very large thank you for you for all of your leadership and your expertise and your wisdom over many years. That's made such a difference to the population in Wales. So it's a shame you're not with us because we can kind of recognize. Oh, so we have to sort it online. So people watching it. You have to. Clearly we weren't going to let you in, so So anyone watching online, the Teams version of clone of Zoe is now in 3 dimensions, actually in the room. So Zoe, did you hear that?
I did. Thank you very much.
But I mean, huge thanks, because it wasn't for your leadership and your perseverance and your commitment and passion to make a difference, there is absolutely no way we'd be in a position of what the board is about to hear. So just a very, very warm diolch yn fawr iawn, because you will be very, very sorely missed, and we can't persuade you. Well, actually, I'm really pleased you're coming back in November for 3 days a week.
I can hear it.
The answer to that.
Yeah. So Zoe, we'll hand straight over to you, but I don't know if Meg or Kiri wanted to say anything.
I just want to echo your thanks. Zoe's been phenomenal in setting up the test host service, which has really served the population in Wales well, and over and above what we've seen in other nations like the United Kingdom. And that has meant that we've got a better understanding about the threat of sexually transmitted infections in Wales. We've seen a tenfold increase in testing activity, and therefore that gives us the foundation for understanding true prevalence, because many of these STIs are hidden and remain undetected without this accessible service. So Zoe's here to talk about that service, but also in the context of everything else we do around sexually transmitted infections, not just the diagnostics and the health protection services, but also the proactive work we do around contraception and raising awareness around sex and relationship education in school settings. So, Zoe, over to you.
Thank you. You can't hear me, tell me to shout. I can do that. Okay, just to give you a background, sexual health, we all know, is influenced by so many different things and is so core. It's important to recognise sexual health and well-being. It affects physically, it affects mentally. You get your relationship right, your mental health improves, etc., etc. Good sexual health contributes an awful lot to society. Not saying that the extension of society, shall we say. But also, if you have poor sexual health, that is a major drain in terms of the health service in particular, and that can be around infection. And if you think about an STI, the most logical one to talk about is something like HIV. But if you think about that being diagnosed late, you have ITU beds taken up, and an ongoing problem in terms of other health issues associated with it. So essentially, when it comes to sexual health, it can be actually described across the 3 domains of public health. So on the ground in Public Health Wales, when those of us who, impolitely I'll put this, are on the ground, there's an awful lot of work that's being done across the different directorates. And that goes from education, health schools, primary care, through to policy, behaviours unit, through to CARIS, our congenital anomaly register, and they're working with us at the moment around HIV, hepatitis B, hepatitis C, and syphilis diagnosed in our pregnant population, and then the ongoing impact of that. Lots of research being done across different teams, and of course our comms colleagues are heavily involved with, certainly with us. They have to meet me every week at the moment, so we're to try and make sure that we get sexual health on the programme constantly. So so in order to coordinate this, Maine's asked for a group to be set up, and the purpose was to actually look at what we're doing across Public Health Wales in terms of the strategic direction, the governance that we have, and to make sure that we've got some consistency in how things are delivered, and make sure a work plan is in place so that we're not stepping on each other's toes, but we're actually working collaboratively across the organisation. So, proposal for a framework is that we're aiming for optimal sexual health and wellbeing across the lifespan for the people of Wales. The mission encompasses all aspects of sexual health, Public Health Wales. It's based on the quality standards, safe, timely, efficient, equitable. I'm going to say equitable a lot rather than equal, because that's important. And the background is related to what is already happening, and making sure that we've actually got a map of what is happening already across Public Health Wales. We need to look at the resource to deliver, and that's not just in Public Health Wales, but how we work with our various partners, many partners across Wales, who are often better placed to do things, but actually if we work together, we can deliver far more. Life course approach and strategy, and there are very many outputs, outcomes, and then we can measure the impact quite easily for sexual health. And it's more than how many STIs, how many contraceptives, whatever has been implanted. So the Public Health Wales role is around education and training, and that is for all service providers, service users, all people, because even as a service provider, actually, we have sexual health needs as well. Information has to come from a trusted source, and that's a matter of countering misinformation by being a trusted source that gives the correct information, as opposed to going, that's rubbish, you can't do it that way, we all know that doesn't work. Behaviour and engagement, and that's of the populations, but also of service providers, because if a service provider has a certain view, that tends to come across during that engagement. And an awful lot of data and monitoring and surveillance, because without that, we're not going to be able to do the service planning and the changes that are required. So, strategic alignment, Welsh Government has a sexual health programme board chaired by the CMO. It always has been, and that is continuing theme. Isabel's taken on that role as well. There are oversight groups for the HIV Action Plan, elimination of Hep B and C, the Women's Health Plan, and if you go wider than Welsh Government, if you go internationally, you've got the World Health Organization's elimination targets for 2030 for STIs as well as bloodborne viruses. And there are sexual health priorities paper being agreed currently in Welsh Government. Right, just to give you some background as to what's happening in Wales. Number of individuals, this takes us to 2024, being diagnosed with chlamydia, gonorrhea, syphilis, that's our key markers for STIs, and the level of positivity. So our numbers diagnosed have increased slightly, but that's fine because so has the testing increased. So the important one is the line. So positivity is, thank goodness, beginning to tail down in I'm hoping 2025 does exactly the same. So it means that by testing, we're actually getting people treated, which means that we reduce the pool of infection. That's the considerable hope that we have. Not so good. Number of individuals receiving long-acting versus contraception. So that's your coils, IUDs, your implants, and to some extent the injectable. Injectable, is a medium term, 3 months. That's dropping and it's continuing to drop. And there's lots of reasons around that, including lots of social media misinformation around hormone contraception. Not surprisingly, to go alongside that, our abortion levels are going up. And it's not the teen pregnancies. It is the next group up that is the bigger concern. And then we've got the, oh dear, it wasn't menopause after all group. So just to bring it into my own personal patch, the sexual health programme is part of the community called Disease Inclusion Health Programme. So we were 3 programmes, substance misuse, sexual health and health and justice. We've always been based in the Health Protections Division. We've always worked together, but this formalised it a couple of years ago for us. The reason that we come together is because we tend to work with the inclusion health groups. It's the Inclusion Health Programme. And that is because they are, for the most part, those at higher risk. And they are not a hidden population. They are not hard to reach. They are, however, generally underserved. So that's the group we tend to work with across our programme. This is our entire group. So this is your substance use programme, this is your health and justice programme, and your sexual health programme within Public Health Wales. The yellow highlights are, we're missing our deputy director at the moment, are the 4 posts that we have had put in place since June on a temporary basis. So we will evaluate the impact of that. I obviously have a personal view as to the impact of that. One of our staff saw 700 people, or engaged with 700 people in Cardiff Met yesterday. So I think it's very valuable, and I've done one of our events. So what we actually do is provide information and training related to sexual health. We support research, and that is across the whole of the UK, and evaluation of all the related projects. We have a phenomenal amount of data from Test and Post in particular. We also support the condom card schemes across Wales, and the main thing we do is run the Test and Post service, which is online, it's community kits and it's condom provision. Just to let you know, the website will be migrating to the Public Health Wales website. This has existed since 2012. It came into existence as a website for an HIV campaign that was run in Wales. It was called Frisky Wales. Everybody remembers it vaguely. Actually, lots of people come to us and go, "Oh yeah, I use Frisky Wales." They still say it. So the reason it was called Frisky was for risk in Wales. It was a focus group that put it together from population who were concerned about HIV and were living with HIV, and they did not want to be seen to have HIV in the browser. So that's how the name came about, and it was only about HIV. Then over the years, so since 2012, it's just been added to progressively. The content of the website comes from the experts that actually deliver services and have the knowledge around this, including things like Relate. The adoption pages are seen off by Adoption Wales, that sort of thing. The reason I wanted to highlight this with you is, okay, so the top hits are Test and Post. That's 50% generally of what goes through that website. It's 0.6 and 0.9 abortion is the page that's looked at as the 6th. Contraception is number 9. That, in an ideal world, would be the other way around. So we also have our C-card website for Wales, which directs people to where the different C-card schemes are, and we hold the National C-card database. C-card is the condom card distribution that works with 13 to 25-year-olds. It has various coordinators across Wales. Some are run by public health teams, some are run by local authorities, some are run by charity third sector. All of them use the QES system now. So we have the data about how often people register, how often they attend, what they actually take with them, how often they are referred in for safeguarding, drug referral, drug and alcohol referral, etc. With the test and post service, month in the life of, we get approximately 8 to 8,500 kit orders per month online. When I say a kit order, that can be anything from a vaginal swab or a urine test through to 3 swabs and a blood test. Kits. These are the ones that are used out in the community, but various of those. Condom requests, around about 3,500 requests per month. We send out roughly we do send out half a dozen condoms each time there's a request. And then we'll get people who will come to our inbox and go, actually, I'm a sex worker. Is there any way that I can have condoms in greater volume? So we work directly with those people. And equally with other services that are in contact with a variety of different areas of the population. Our inbox, we get about 1,000 emails a month, and that can range from, I haven't had my test results, can you check? I'm a bit anxious about it. That means I posted it this morning if I haven't got a result yet. So we always want that, we go back to it. That's one end of the scale. The other end is we've been partying in London, we've come back, we think we've got Mpox. What do we do? Please don't leave your home. We will sort out how you need to be following up. So you have that conversation ongoing. Through to my daughter's come home from college, she's been raped. What do? We want to just do the test and post, because she won't go to services because he told her it was her fault. So is it okay if we just do the oral swab? Will that tell us that everything is clear? No, it won't. You're going to have to do more than the oral swab. So you kind of, that turns into a phone call, and you go through the process. Kit returns. For chlamydia and gonorrhea, we use urine and we use flot swabs, and it's an app test, and they get about 11,500 returns of those a month, and for our blood returns, about 3,500 a month, and it's a microtube that's used for that. The referrals from test and post to our sexual health services for anything reactive or positive is about 500 a month, and that is all infections. So we do see all of the infections during the course of the month. Our little team at the bottom, that's our packing team. They don't see the light of day too often. That's why they're on the slide. And that's our condom station, as it were, the coloured boxes. Different colours, different type of condom. For our community kits, we've been doing this since January of 2024. We have now sent out, we've probably hit 30,000 by now. This is to the end of August. 206, we've called it services because 260 services equates to a lot more venues. So, for example, Cardiff Council Library and Hub Service, it's 20 different libraries and hubs, you can go and pick them up there. And it ranges from that through to sex on premises venues, through to websites that arranges for parties. And then we have 170 pharmacies out of 700 who have also joined us through this process. Community engagement. You have to do this, pick a photo where nobody's identifiable. It's quite challenging, I have to say. So this is what we look like when we go out into the community. So we have our pop-up banners with the QR code, which people use, but we also give business cards. Our events attended in 2025 range from Aging Well right the way through loads of prides. There's been 30 plus prides this year. The Ministry of Defence, so the mods and Athens, that sort of thing, we go out to their events. Beer markets, homeless shelters, their engagement days, substance use service engagement days, probation, we do right across the whole patch. In terms of training events, all the youth workers in the earth have had a training session, and they have the kits through to schools, hospitals, and it will be providers but also service users that are involved in these events, additional learning needs and universities and colleges. We do lots of research, and we're just teeing up for the Text-In for testing, which is going to be an expansion of what we've done previously. Oh, too far. And for the future, she said, dropping the mic. Prep, we're in the process of putting the e-form together for self-referral. There's a question on the process that you go through, because it's a virtual clinical session, basically. If somebody says they're interested in prep, they will be taken to an e-form instead of a page that gives them a phone number, so that they can actually self-refer into the services to access prep. There's a contraception pathway that's partially written, again, trying to encourage people to have that link into the services. We are been approached by the substance use services, but also by representatives from the trans community around trans injecting, both from a point of view of doing it safely, properly, knowing what you're injecting, but also to talk with us about whether or not wedding loss could have a role in assessing the DIY hormones that you can get on the website and on the internet. So that is another step that we're exploring: ongoing community engagement and ongoing research and evaluation. For the future, safe practice for chemsex. It's a difficult one, not a difficult one at all, actually. You can do it online. Chemsex is an issue that is really, really difficult to get evidence for. We've had a survey that we ran from 2019. We've got about 90 answers on it. But if you talk out in the community, chemsex is used an awful lot. So it's whether or not you actually look at generic post-generic condoms alongside needles, syringes, etc. Dare I say, safer intervention devices. Prep in the future, working with the sexual health services, etc. Again, being an online conduit for that, to make it more accessible. Community pharmacies hopefully will have it in the next year available. The pilot hopefully started in December in Cardiff for community pharmacy provision of PrEP, working with the sexual health service. DoxyPEP, another one that is up there now. The oral pill, again, working with other services as to how we provide it. Sexual health and case management. We're trying to work out how long this has been rumbling. I think the first time we mentioned it was probably around 2010. It's still not resolved, but hopefully it will be in the next 5 years. But that is an enormous one, because if you don't get that right, then you won't be able to monitor what's happening. We know the data we've got is under, the long way under what is really happening. So that is it. Sorry, whistle stop.
That was lovely. Thank you, Zoe. That was incredibly interesting. It was really good to have you. And we got questions or comments from colleagues. Beth?
Thank you, Zoe. It's fascinating to see the reach as well.
Mhm.
I was fortunate enough last week to sit on the panel for the consultant nurse in sexual health, who is not going to replace you because the service is not replaceable. And unfortunately, we didn't appoint. So just some concerns that this good work continues to be on. We've got some vulnerabilities in the team with some leave planned.
Yep.
So it's just making sure that we've got a really robust plan on how the execs can help you maybe test out what that is. So that was one thing.
Yep.
And great to see the work presented there. The second issue was just that some of this is quite clinical technical, isn't it? There's a lot of guidance and things. Where will the team get that clinical advice in terms of treatment protocols and guidance? You were saying about what swabs you recommend it. So where did they get that from?
So the photography pound,
Okay.
so that is done through laboratories that we have contracts with, but also the guidance we get from our Sexual Health Wales Advisory Board.
Okay.
Council. But we have representation from BASH, from what was FACTI and now College of Reproductive, Sexual and Reproductive Health. We have government colleagues on that. We have screening colleagues. So they provide an awful lot of support. Our network for everything to do with test and post is into every sexual health service in Wales. So we get a result, it goes to the area that the person's address is in, unless they've told us that they want to go somewhere else. So if you live in Cuptar, but work in Cardiff, there's in seen in Cardiff, then we'll send it to Cardiff, and they will be followed up through that process. Does that help?
Yeah.
Thank you. Really interesting. Years ago, I used to work in the sexual health service, so I'm really interested. But that's one thing about for the future. If you look forward, you're providing an independent, an isolated service. So how well networked are you into the GP world? And then it comes to your data, your data and the service, the management side, and needing to have a proper surveillance system.
Yes.
Because you probably need to be working pretty closely with primary care, with pharmacists and GPs. Is that the future to move forward in that way?
So we work with community pharmacy in Wales already. Sorry, I didn't explain it very well.
No, well, you told it future man. I'm like,
sorry. So yes, and the GPs, we go out with GP practices individually so that you get everybody in a GP practice that understands what the process is, what we have. We have GP practices as our outlets for community kits as well. We go to the GP training days, which we linked with Kerry Bailey's team in primary care with, and Zoe Wallace in primary care. So we have those links across, plus GPC Wales and Welsh Government's primary care and pharmacy in Welsh Government as well. So there are lots of network links through the whole process.
I suppose being part of the knowledge research and information community, I would go,
Yeah.
How do we know what the outcome of your work is? It's a very, very difficult one, but I think in terms of actually development for the future,
Yeah.
how would we know what the outcome was? I mean, I know we all feel we know what the outcome is, but
No. So the sexual health case management system has to be done separately because of the legislation in Wales.
yeah.
You will well know from your experience.
Well, I was just thinking that's why you're still in the substance use from the age of 1948, so the legislation, yeah.
Yeah, so we're still on 1918 basically, well, 1974 if we go, Virgin for Sexual Health. So you are immediately not the same person when you get referred in. Having said that, in an ideal world going forward, because we have all of the data about the person quite easily, it's just on our test and post system, the idea is that there will be a link between that and the sexual health service system going forward. So that person does become one person. Equally, the person who goes to Swansea for their treatment and moves to Cardiff then doesn't become another person. Yeah, exactly. Yeah. So you end up with an individual record which has all aspects, and also the GP element will feed into that as well. Most GPs are really keen to get anything that they think is sexual health away from them and actually into the sexual health service. But frankly, they're encouraged to do that as well. The last session I had about BBBs with the GPs, they were really, really anxious about actually talking to somebody about doing an HIV test or even a B test. And one said, well, we can give you the kits, and then the results come back to us, and if it's reactive, we send it to the sexual health service. You're out of that loop completely. And we were like, oh, right, well, that's great. Where do we sign?
Except that if you phone, they have to go back in again.
We've got a great long queue of people wanting to ask you questions.
Sorry.
No, it's not you. I feel it's really, really interesting, but I know Liz online has to go, so I'm just cutting it a little bit short to give Liz an opportunity to ask a question, and then I've got a further queue of 3.
So it's said, maybe it's a separate button.
This question I have very.
Yes.
No, it's been like it all week.
There's a further question in the chat for us, so I'll just read it out. It says, I work in a lab and I'm often working on gonorrhea and antimicrobial
Yeah.
testing.
Yeah.
So interesting to see the full story behind it all. I'd like to ask whether we feed into antimicrobial resistance monitoring and informing pharmacies / gov clinics about what OTC treatment to give empirically. Is this linked with other areas of PHW?
Yes, antimicrobial resistance team, and, sorry, I don't know which direction to look in. Yes, Liz, we link with the lab in Cardiff as well around gonorrhea resistance in particular. And the reason for that, even if we have a positive gonorrhea through our test and post service, that goes to the clinic, they will do a further swab for the resistance pattern, which goes through, I was going to say GRASP as the original thing, but through the lab Mandy Wooden runs. So that ties in. Yeah, it's all very tied together.
That's it.
Thanks, that was really interesting. And I have two questions. One, you touched on, Rashan, that I didn't quite grasp, which is why is substance use and sexual health within the same kind of family? And then the other question was the structure is, do we have sexual health clinics that are Public Health Wales sexual health clinics, and then we work through partners, or is it all done through partners?
So all of the clinic face-to-face is through partners. So our activity in terms of clinics is a virtual clinic online. Then if you have somebody who's got a reactive result or a positive result, they go to a physical clinic or are linked into the clinic in their health ward area. So CRI, for example, here. Does that make sense?
Not so we don't have sites, say we have our screener sites, we don't have clinics which are Public Health Wales sexual health
No,
clinics
not
around the
currently.
country.
No. Wait for HPV self-sampling, yeah. And as far as substance misuse and the sexual health group coming together, it's often the same population. So rather than you go somewhere for your substance use, you go pick up your needles, etc., but nobody talks to me about sexual health. It's how we actually tie that together, because it'll be the same people that have visited so many times over. So it's actually dealing with somebody as a whole person rather than in bits.
Interesting. I'm just wondering if the way you describe sexual health is very kind of encompassing of everybody's part of their life.
Yep.
Whereas the substance misuse can carry stigma.
Yes.
So I'm just interested in why they collapse.
Both STIs, so HIV and stigma is huge, but actually you're talking about population. Luckily, substance use and HIV in Wales, unlike other nations in the UK, so far has been okay. We don't have much injecting use that's resulted in HIV infection. That's very, very low. And generally speaking, it's in people who have injected in other countries who have been identified as that's their route of transmission. Our bigger problem would be, for example, in that population, they are substance injecting, but in order to fund it, they do sex work. And that's the connection for that.
Ben, I think you were next.
Yeah, I just wanted to come back on the point you raised, Alison. I think there's no easy way of structuring ourselves, but there's sufficient commonality between those areas to form a program to look at communicable diseases from an inclusion health point of view, but recognizing actually for sexually transmitted infections, that is very, very broad church. But there will be some communities and pockets that will need that inclusion health focus, homeless, people in prisons, etc., which is why the health and justice team are also in that inclusion health program. But recognizing that there is a much broader agenda that the team will look at through the sexual health lens. I also wanted to come back to update board on the sexual health case management system, which has been an ongoing need in Wales for a long time, because the local health boards are now creating workarounds for this system in 7 different footprints. And that means that there is potential duplication of references, and we're not able to then understand the surveillance of this. So there's a need. And I'm pleased to announce that the funding has now been confirmed for the next phase, which is to undertake an alpha phase for this. And after that, we will then be able to identify clearly what the revenue and capital spend and the investment will then be required for the system.
Sorry.
Really hard to hear about the work that's going on around early intervention and prevention. I think you referenced an event at Cardiff Metropolitan
That was
University.
yesterday, they're
Is that
Cardiff
better?
Union today.
Yeah.
So they, over the summer, through Pride events, they've seen nearly 3,000 people. And when I say engaged, I mean like meaningful conversation as opposed to. So yes, I have to say member staff is probably going to float both the.
I'm sure the impact of that is very effective, even if you can't perfectly get stopping people having things, but still we know, I'm sure there's evidence. But what I was going to ask, because actually your team is not a huge team, you know, are we reaching all the people we'd like to reach? And yes, I thought the answer would be no. How do we grow the capacity for other organisations? So, for example, working with youth services across Wales to make sure youth workers can deliver some valid advice and information.
Yeah.
So, how effective are we in building that capacity? And you know, is there? I'm sure there's a need for greater capacity to build the capacity, but
Yes.
I'd be interested in that and how effective that is.
So the 4 posts that we've had since June means that we've actually been able to kind of open up the idea of not only the events. The events are kind of, she said in a hopeful voice, almost coming to an end. So essentially Pride in Wales starts in April. Right. That finishes end of September. Then you hit Freshers. The last of which there's been a lot of Freshers. Also, like Tanya, this year's Freshers are very different from previous years. So massive engagement. Not the mousy little Freshers that we had 2 years ago. This is huge, and it's not being practiced. You know, and there's always one that'll blow up a condom and walk around with it. You know, we've all been there. Let's face it. You know, but this year it has been very much around. We're talking to them about PrEP. We're talking to them about getting vaccinated. We're talking to them about actually using condoms. We're talking to them about you get an infection orally. This is news to a lot of people. So we've got DAMs. So thank goodness finally, and latex-free ones as well. Although they look like a face mask, it's got supposed to go on the legs, not around your ears. That's been an interesting conversation too. So that is all unfolding quite nicely. We've worked with lots of different. There are so many. When I saw sexual health deep dive, I think I would have nothing go there with this, so I won't. I'll move on. We work with a lot of partners. So, for example, Cardiff Union now, it's the YMCA sexual health outreach team that is working with one of our members of staff, so that hopefully that'll expand the amount of stock we've got as well, because we got through 2 body bags worth of stuff yesterday at Cardiff. They are body bags. They are big bags. So we are literally just working with lots of different teams across. Fast Track Cymru, the first fast track nation in the world, and Fast Track Cymru is a coalition of local authority, health, and third sector. Work right across that. So we partner with them for lots of events, side plans, all that sort of things. So we'll go to some, they go to some, we'll share our resources, the of the information that we can spread. So it's maximising that the whole time. The team now events from onwards, and that's workers in places like substance use services, I said about the youth workers in years. So there's full frame second of that. So it is maximising and improving those relationships with and making more, because we've got people coming to us all the time going, beautiful use of kits as well. We've got people who come to domestic abuse services. There's an enormous risk. Our sex on premises venue, that was can you come and talk to us, and we'll sort of things like get wide. So that's been done with ourselves and with Mansfield.
Really want to match it. Let's just one last quick question about colleges. Do we work with colleges?
Absolutely.
Right, okay.
Yes.
Brilliant.
Yeah. That's part of the Freshers' Joy as well, and ongoing with their wellbeing officers and with pastoral care officers in the weekend.
Thank you, Zoe. So I've got a list. First of all, to add my thanks to everybody else on behalf of the board for everything you've done and for what has been a very, very engaging session that's taken me completely out of my
Sorry.
But that was absolutely brilliant. And yeah, thank you very much and good luck for the future. And we will arrange some sort of board visit to the next one of these events, I think, at some point.
Wonderful.
Absolutely. I want to go packing. That's very
Please do. They'll give you a whistle stop tour of the ballroom.
I think we can all note and take assurance that there's quite a lot going on. Thanks, sir. Thank you, sir.
Can we also note that we'd like to know more about the case management system development?
Yes, we can.
It's £2,000 this year to Welsh Government.
Yeah, but that
For the
I'd like them to keep going, as it's been waiting around for
Yeah. We
2012.
let's commit to provide a report after the alpha phase.
Yeah.
When was that?
Well,
We just got the money.
Ian, when was
we
that?
just got the money.
Well, we just got money, I think.
No, but when-
Give us a chance. Yeah, I know,
I'll give you a chance.
Yeah, I just said it probably, let's think if it has been either January or March, or it would be reasonable for it. Yeah.
Thank you, I'll remember.
Yeah, we've got a note. Got a note. Brilliant. Okay. Okay, so let's move on then to the board assurance framework.
Okay, still Borodar, I think, yes, Trish Cooper Edwy, you'll notice this, it's a slightly shorter report this month, and obviously with summer period, not that it was quiet in the summer period, but there's some really great items here. So as always, take it as read, and I just want to highlight a couple of items that I'm going to bring some colleagues in to add a little bit of colour to them. So the first item, which is just fantastic, which is the designation as a second WHO collaboration centre, this time on digital health equity. We already have the collaboration centre on investment for health and wellbeing that Samina and the team chairs, and I'm going to bring Ian in a second. But this is just fantastic development, and I think it's a real testament to Ian and Alicia, particularly Alicia Davis, who's our head of research and evaluation, who have been doing a lot of stuff internationally, but obviously for Wales and the UK, and leading the way around digital health equity. What I would say is that absolutely does not mean that we have got digital health equity cracked in Wales. There's a lot of work to do, but we see this as being a significant benefit for Wales, and for us to be a conduit to learn and share as a collaborating centre. My final point before I ask Ian to come in is, as with our existing collaboration centre, we wouldn't be doing any additional work here that we wouldn't ordinarily feel is a benefit to Wales. It just brings that international lens in more prominently. So I think it's just fantastic. And we will be organising a launch with the Minister for Mental Health and Wellbeing, who has this portfolio. We're just trying to sort that out, obviously let the board know. So Ian, I think may want to come in on this.
Yeah, thank you. And I'd like to really reinforce the point about Alicia. This is really all down to her and her leadership in this area. She spotted the gap, built the evidence base, and drove it forward. And it's a real recognition of her thinking about this very differently. And thinking of digital health equity, not just as being about access, but into actually how everyone has the opportunity to benefit from digital developments and bring it on. We'll be working closely with Welsh Government and all partners to make sure that the work programme really benefits and drives the improvements to health equity in Wales. As you said, Tracy, nobody has this cracked, and it's how we can work with others and actually access to other countries who may be doing innovative things which may help us as well and how we do it. So really delighted to be here, but hard work starts now, really.
Well, and it's your leadership, Ian, as well, you know, to bring us here. And what's going to be key is obviously it's unusual to have two World Health Organization collaborating centres in the same organisation, and it's how Ian, Samina, and the learning from Samina, Mariana, and our pre-existing team, because we obviously will want to make sure that they're very integrated in how we approach our work, particularly because our pre-existing collaboration centre, the focus is equity as well, and this brings the digital health equity. So it's just, you know, fantastic. Next item is around exercise Pegasus, which is the current live, albeit in between phases, UK-wide pandemic preparedness exercise, which is fair to say it is probably the most real and concentrated exercise that the UK has run, although there have been previous exercises. And we are very, very closely involved, as you imagine, with significant numbers of staff involved, working closely with obviously the Welsh Government and partners, but also our counterparts of UK public health agencies as well. But I wonder, May, if there was anything you wanted to add.
Thank you for that. And, you know, the exercise is run in 3 distinct phases. The emergence phase, which is phase 1, has now completed. And just want to take the opportunity to thank Tom Fowler, Wendy Shepherd, and Hugh Williams for their leadership and coordination to ensure that we played a very active and critical role in the response from Public Health Wales. And we were engaging at a local, regional and national level, working directly with Welsh Government and our strategic partners. I think it's safe to say we are taking stock of the learning from phase 1 to inform our response to phase 2, which will be the containment phase, which will run in 2 weeks' time.
Thanks, Meg. And just to echo the thanks to Tom, to Hugh and Wendy, it was a full-on week with 46 of our staff actively involved last week and into this week. And as Meg said, Wendy, Tom and Hugh were utterly exhausted by the end of the week, but really did us proud in helping navigate us through. So a really big thanks to them. Also, we had our annual general meeting last week. And I'm saying that with a smile in my tone, which we did over in Carmarthen in the offices that we use, which are SLC offices, and many of the board were there, and it was a really great event. And we had fantastic speakers. It was nice for our infectious team, our microbiology team in West Wales to be able to showcase the work that they're doing, supported by Robin, and we had Jim, Rachel from Diabetes UK, covering Rachel, not Jim, who gave an excellent presentation also around what we do to prevent type 2 diabetes. And obviously we fulfilled the requirements of an AGM and launching our annual reports. And Neil stood in for Angela and did excellently around presenting for our financial position for last year. But a really big thanks to Steph, to Liz and to Paul for all of the organisation that went into the AGM. It was a really nice buzz. And we had, as I've said here, you know, actually considerable interest of people who attended it. So yeah, that was great. And then last 2 points, just fantastic that we've got 3 of our wonderful nurses across the organisation who are finalists in the Royal College of Nursing Nurse of the Year Award. So that's Rachel Evans, Louise Mann and Annette Blackstock. So we wish them all well. And I know Claire's going to be living every minute, and it's November that we'll hear. And whether they are successful or not doesn't matter. I mean, they're finalists, and that is just fantastic. Really, really proud of them. And then just one final thing on an update of the UK COVID public inquiry. You've seen the comments of where we're at or where it's at. But the only thing of particular note I would flag is that the inquirers advised that the report from modules 2, 2A, 2B, 2C, which were all about UK government and all UK for nations decision making during COVID. So these were really significant modules. So it was a UK government stroke England and then Scotland, Wales and Northern Ireland. That is being published on the 20th of November as a combined report. So Paul, myself and our senior counsel, Deborah, will be in attendance so that we're able to read it embargoed in advance, and we'll have a conference call of a number of people as permitted by the inquiry. You can imagine that this is tightly controlled during the day so that we're on the front foot, and then it's published at 4 o'clock in the afternoon. And that's what I was going to say. Thank you.
Oh, lovely. Thank you, Tracy. Any comments, questions?
Just congratulations on the WHO
Yeah.
Gathering Centre to Alicia and Ian and the team. Fantastic, really good. And what Ian didn't say was I challenged him to find digital equity quick, and so he looked it up on ChatGPT.
Exploitation is alive and well.
Yeah. So if you want to understand it better.
Lovely. Any others? No, in that case, like it's an echo for me. It was a report full of well done's, really. I was very chuffed with with the RCA and with everybody who participated in Pegasus, and obviously the WHO Centre. So that's fantastic, and I think again we all can take assurance. Lovely. So on to the latest public health overview, and as always, it would go to Ian to start us off.
Pertanda på inbound UI cyfarwyddo local data and digital. And so, well, I'm Ian Bell. I'll give a quick overview of it. I'm going to start because we had a prolonged discussion last time around smoking data. And there's a bit of background I want to give here. It's that since the board paper were published, the National Survey for Wales gave its latest update on the prevalence of smoking. Now, it's worth bearing in mind that every bit of data at the moment that comes from survey comes with a caveat and caution because response rates have been falling across the board here. But the latest prevalence estimate was a fall in Wales down to 10%. And so broadly, this aligns with kind of what it's not quite the same as the chart we got in the dashboard, which is kind of pretty flat when you distinguish it. And so where we're getting here is we need to do work. Also, we've got to then take the lowered response from the National Survey for Wales, compare it with the lowered responses from ONS data, and try to work out the comparisons with England as well, but at the moment it's slightly lower. So I think there's cautiously optimistic news here around the smoking prevalence. But we also need to work, we've been talking with UCL about the data in the dashboard, and they're also concerned about the level of variability in it. And so we're going to look at how we present it for you so that it makes it easier to discern a trend there. So that was a quick overview of smoking. Reason to be cautiously optimistic, bearing in mind the number of caveats, even for me as a statistician, is large on this one, on the data there. On the other healthy behaviours, I think we're not really seeing any significant trends at all. We did see that upturn in problem drinking over the winter period, but that seems to have gone back down, and it's difficult to decide whether that's a collection or data issue or a real world issue. It could be either, and we're never quite going to get to the bottom of that one, I don't think. In terms of mental health and well-being, again, it's a very stable picture there. There's not much change going on. Wider determinants of health. I want to focus particularly on the cost of living part of this. The labour market picture is quite static, if we like, in that sense. But on the cost of living, I think I really still want to highlight the significant issues which are still facing a proportion of our population. It's around a third of the population in Great Britain are reporting problems with either rent or mortgage or with their electricity or utility bills. And that's a significant percentage facing those challenging circumstances around actually what are core components for health and well-being. In terms of economic inactivity, again, we're still seeing the overarching trend here of high levels of long-term sickness, which are impacting levels of economic inactivity. And we've been doing work with Neil, Jim and I with HEIW on a joint objective on how we can actually work with our own workforce to help turn that round, as well as thinking wider into the community through Healthy Working Wales and the like. On communicable disease, on the kind of communicable disease aspects, I think I do want to highlight that continuing good story on antimicrobial resistance, where the Crown continues in a positive direction, which is really welcome. And then finally, I'm going to finish around the way the referral to treatment pathway times. Our analysis of healthy life expectancy is showing that that may be a significant driver of some of the declines we're seeing in healthy life expectancy. And so while it's coming down slowly in most specialities, actually it's not coming down very quickly. And therefore we need to think of it as being, how can we work with the system in order to do that? So that is my whistle stop overview, Chair, and as always, happy to take questions.
Thank you, Ian. Do we have questions, comments, Tamsin? Straight in.
Thanks, Ian. I interpreted the drinking slightly differently, because I felt like everything else was pretty kind of steady and static, and the drinking was the only one that kind of showed a kind of significant drop or reversal. But I guess my question is, it seems that the figures seem stubborn. You know, when you look at the graph and it kind of, there's a little bit of movement. Generally, everything seems to be kind of in a stable kind of pattern, if you like, on the graphs. Are we considering that a win? Are we considering that we're holding things steady a win? I mean, that it's a question of what's passing. Are we able, are we, by not going into a negative situation, are we considering like we're holding something back? Does that make sense? Is that question not well framed?
It does. It makes perfect sense to me. I think this is kind of where, and I'm going to tie it through, because we've got work to do on this on the outcomes framework side of things, but I'd link it through there. These are early indicators about what might be going on. And then we'll know both through our delivery mechanisms, actually, is it going well or not, through the performance indicators, but then also our evaluations, which then will tell us whether actually what we're doing is making a difference or not in order to do it. If I had to take given the kind of relatively flat and stable state of the economy and the cost of living, I think you could argue that actually holding things like healthy behaviours and other things, that it is relatively good news. But I'd want to take it away and give it a lot more considered thought than an off response. It's a really challenging and good question. I'd like to take it away and give it more rounding thought with my exec colleagues.
On a slightly, so on the promoting mental and social well-being section, the kind of frequency on all of the graphs has all altered towards the end tail quite significantly. When you look at it visually, is that something to do with the way that we like the information reflecting at different points in time, or do you think there's something underlying that in the way that the graphs are all changing?
So my understanding of this, these data are from a Great Britain-wide survey run by the Office for National Statistics. They have been looking across the board at their survey collection activity, and they cut back in some areas. It was an ultra-high frequency during COVID and beyond. And I think they've now pulled it back to more of a normal state side of things. There is also a particular thing that this survey, when I received a lot of criticism, and I declare an interest because I used to work there, so I will say that now. They have received a lot of criticism, particularly over their labour force survey, and they've been publishing and the response rates to that. And so they've published a survey and an economic statistics and survey recovery plan in order to improve response rates. But that will focus on some of their key, particularly key headline economic surveys in order to do it. So I think there's a bit of reprioritization. So the frequency is a deliberate choice by ONS to scale back. Yeah,
No, that's helpful.
yeah.
James.
Jimmy Manus TV gyfer with the life o iechyd case. Mae Ian yn iawn am smygu. I'm Jimmy Manus, I'm the National Director of Health and Wellbeing, and that's my attempt at speaking Welsh because gone. I think Ian is right about smoking. I think if you wanted to take this as a sign that the way I think about it is this is probably the least worst scenario in terms of the stability. Is we're holding back a tide, but one of the things we've just done is publish the cardiovascular disease report and plan, because although cardiovascular disease has had significant drops, we're now going backwards across the UK, and we've seen a 46% rise in Wales. So prevention needs to be both about primary prevention, but also about what the NHS can do in smoking cessation. And if you've noted, we're doing a large amount of work to try and get the bundle of 8 up, to get a number of other things up. So my personal instinct, and you can all call me a grumpy Scotsman, is I don't see this as a success. I see this as holding back a tide, and we've got much more to do. And we need to take that complex picture. And it would be a lot worse if the figures were really worsening. So we can take some comfort in that, but we've got a huge amount of work still to do. It would be worse if we weren't doing it. It would be a lot worse, but that's not an excuse to go, yay. Don't invite me to any parties.
I think if I may build on that, I think what Jim's rightly hinting at here is there's lots of brilliant activity across the organisation, but given the challenges of healthy life expectancy and the trends there, the real question for us is whether we're having the size and scale of impact we need against that. Yeah.
And if I could come back on that, I think there's the issue then about how we conceptualize the system. So what is it that's in our gift to do? Yeah. Are we absolutely hammering everything we can? So you'll see new cardiovascular disease work coming on. And there are then issues about what the rest of the system is doing, because it's the environment. And this isn't just a Welsh issue, this is the environment and the system such that it's mitigating for health. We all know that the food environment is such that it's now designed to make you put on loads of weight.
I just support Jim on that, and I think that there are some big challenges on the going backwards bit on non-communicable diseases, and of course inequalities and social and environmental issues are part of the whole picture. Yeah. So it isn't just us, it's how we work with our partners. It's also going to be essential. And one of my favourite things has always been how we work with individual clinicians, getting the clinicians, because the old research, which probably still holds, is that if doctors say something to patients about smoking, it works. I'm trying to remember the name of the study, but it shows. So I think it's about how we work with our partners. It's something we maybe need to keep thinking about.
Should we go to Maine then quickly, just for an update on public health matters?
O, diolch, Claire. Main core dwi, cyfarwydd o'r cenedlaeth o gwasanaethau dioddi Asfinio and the National Director for Health Protection and Screening Services. I want to take the opportunity to report to the board that we have attended 2 major incidents, one relating to a fire incident in the Bryn Mawr area in Gwent, affecting a 150 hectare area with a 1 kilometre fire front. It was a deep-seated and slow-moving fire, a wildfire that had been occurring for a 3-week period, with particular concern about a smoke plume affecting communities in the area. and Public Health Wales were engaged in tactical coordination groups and strategic coordination group meetings towards the end of August and provided expert advice and established an air quality cell to assess the risk. Following the extinguishment of the fire, the incident was stood down on the 5th of September with no reported health impacts. The second related to water treatment work with a burst water pipe in the Bretton water treatment works in Flintshire towards the beginning of August, and initially was thought to have been resolved, but was stood up again when about 20,000 properties were affected, with a major incident declared by Dŵr Cymru, and TCG and SCG were established with Public Health Wales in attendance, and Tracy led the strategic coordination group representation from Public Health Wales. And during the course of the incident, we were actively engaged with the coordination, the communications, messaging, and also the collective strategic response. But after the restoration of the supply of water, the SCG was stood down 17th of August. And then finally, to report that on the 29th of August, Welsh Government announced that a routine chickenpox or varicella vaccination programme will be introduced in Wales from January 2026, and this will become part of the National Childhood Immunisation Schedule, following the decision with advice from the JCVI to recommend the universal two-dose programme using a combined MMRV vaccine.
Some questions, anyone? You?
Thank you, Chair. Welcome the announcement about the chickenpox vaccine. Can we to have reassurance about the timelines to deliver and achieve on that new vaccine programme?
So our vaccine preventable disease programme, which is a formal programme within Public Health Wales, has a team already engaged in the implementation and will be helping with the campaigns and developing necessary resources to support the implementation, which will be delivered by partners in local health boards.
Chair.
Lovely. Well, thanks both. So as a board, we've been asked to take assurance from the discussion that we've just had and the information from Ian and from Maine, and to know the update, obviously, that Meg's just given us. Everybody happy with that? Lovely, thank you. In that case, we will go on to Angela for the integrated performance report and that's by finance.
Thank you, Chair. I was going to say Canspera because I think I'm still in COS, but I'm Dan. I'm Angela Williams, interim exec director of operations and finance. I'm just signing back in because it got me out. Yes, so today we've got in front of the board the Performance and Insight report, which takes us up to the end of August this year. So it's our month 5 report. The cover paper, which is before you, is our assessment of the relevant areas that we feel continue to see challenges in achieving required performance levels. So that's the cover paper, which is there to support the pack of information, and then the Performance Insights report covers 4 sections as normal. Section 1, which is 99 to 115 of the pack, which is our governance and accountability section, and what I'd like to draw the board's attention to 4 areas which we've set out in our cover paper on sickness absence, personal data breaches, externally reported incidents, and incident closure rates. Those were the 4 areas on our assessment of where performance remains challenging or not quite to the level of our performance expectations. So I would just like to turn to Neil to pick up on the sickness absence and any other areas within the people section of the report.
Thank you, Ange. And Neil Lewis, Director of People OD. So just a couple of areas. I'll start with the sickness data as alluded to. obviously at previous board meetings, we've had quite in-depth discussions on this, and we did have quite a detailed conversation at our last people only committee on this as well. In terms of our levels of sickness absence, you will see there has been a slight decrease in terms of those levels during August. We remain above target, and obviously in terms of some of those specific challenges, mental health, stress, anxiety is still at the top there. Lots of work is happening across the organisation in terms of the proactive work in that space, as well as some of that reactive work that we're doing. Long-term sickness continues to be the kind of big challenges, and you'll see 70% of our days lost are due to long-term sickness absence. We continue to work with all our directorates to really look to drive down those levels, and we are doing lots of work to proactively look at the offer and the work that we do with our line managers. And we also have an internal audit which is taking place at the moment, which will provide some more information in that space. We will be taking a further detailed report to our business exec team, and then also having a far more detailed discussion at our next people will be committee session as well. But as Andrew has alluded to, it is an area that we continue to focus on. And then the only other one I would bring specifically to board's attention today is around the agency spend. Obviously, this is a relatively new one that sits within the people governance area. Work is ongoing just to look at that categorisation in terms of admin and clerical. We will be taking a report to the business exec team in October, so we will provide some further information to non-exec directors and board following that meeting as well, just to provide an update on that. So they were probably colleagues that the kind of main areas I've kind of highlighted today, but I'm more than happy to pick up any questions back.
Do we want to pause at that point if there is any questions for the people section before we move on?
It's just interesting looking at the breakdown of 30% character short term and 70% long term. And I think as we do a bit more of a deep dive is that consistent breakdown for us, and how do we compare? I'm just conscious that we're a microcosm of society, and as we've got age-related cancers going up and NCDs going up, it's just interesting to kind of look back and trend it maybe for the last couple of years, Neil, and do a kind of, the short-term sickness, to be honest, I'm not so concerned about. I don't mean I'm not concerned about anyone with short-term sickness, but it's the long-term, it's unpicking that. How much is that as a result of strain, very more work-related, and how much of that is as a result of a long-term condition, cancer that people need treated? So I think that's the bit that I would be most interested to see more of a deep dive on, I think.
Yeah, absolutely, we can do that. And as part of Ian referenced some of the work that we're doing across the system as well, and that's highlighted, I'm sure Ian can add to this as well, in terms of those kind of long term, and what the data is telling us is pretty stark. So again, we can absolutely look to do that deep dive into our own data, and I'm sure with Ian and colleagues as well, look to incorporate some of that kind of more kind of broader All Wales data as well, Ian.
I'm happy to work with you, Neil, on it. I think there is a really important question here about how much are we just mirroring what we're seeing in the wider public sector,
Exactly.
and how much is it there? Yeah, and I think it's really, I'm happy to pick it up with you, Neil, and work through the data with you. Well, get somebody more expert than me to do so.
Thank you.
So the other three areas within this section that we've drawn out in the cover paper are in Claire's areas. So Claire, personal data breaches, extremely reported incidents, and incident closure rates, where were our assessment of where the challenges lay.
Yeah, Angela, Claire Birchwood, League, Director of Nursing Quality and Integrated Governance. So the areas within the pack are on page 1356 in the IPR that relate to those issues. In terms of the information governance queries, so we continue to meet on a weekly basis with the teams, myself and Ian co-chair those meetings to try and understand the nature of the information and queries that are coming through and to really track down turnaround responses and hold people to account for turning those around. And we've started to see some real improvements in those areas. To note, we are finding that our FOIs are becoming far more complex, involving multiple partners and some quite sensitive issues as well. So they are taking a lot more time, and we've had a number of cases recently where we have taken legal advice. But again, we are all over it, and on a weekly basis we track progress and escalate any issues to the relevant executive. In terms of data breaches, one of the areas that we were challenged on last time appropriately by the board was around not just the number of data breaches, but the number of people that affect. So going forward in the performance report, we'll start to identify that, and you'll find in the in focus section a lot more detail around what the nature of the data breaches were. So again, more assurance being developed in that area. In terms of incidents, one externally reportable incident, which was also an NRI, which we reported to Welsh Government, where there is detail in the pack, it relates to our Tarian system. I will bring men in if there are any particular issues that you wanted to pick up, but it was related to a more of cases where the appropriate opening of the case hadn't been actioned on Tarian related to the system, and so generated a significant look back exercise and an IMT looking into the impact of that with the team looking at the original preceding 3-month period to track down any potential harm. There has been no harm found to date, but that work continues. And then finally, in terms of incident performance, really disappointing to see that incident performance after having a really good run of improved closure rates had deteriorated. It is to some degree linked to increasing numbers of incidents being reported, which we're grateful for because we want that reporting culture. But unfortunately does now relate to those single points of failure, particularly through the summer months where people who've got the skills to close incidents are not available. So we understand where those areas are. I now have a weekly safety huddle with Men's team and my team, where we look into those ongoing incidents which are tricky to close. Some of the very long waiting ones we understand are affecting hundreds of people because they are system related. But we've got a much tighter grip on that going forward, and we're trying to get into those services, particularly BSW and DESW, where they generate more incidents because of the volume that they see, but to work with them to close those incidents down appropriately in a more timely manner.
So Meg, was there anything you want to add to?
No, in relation to the Tarian incidents, the 2 incidents there, one of which has many more individuals implicated, but from the assessments so far is that there are no clinical impacts emerging from those. So I hope the board has assurance of that, but that work and the investigation continues.
Any questions for Claire on that section?
Just one other question, actually, going back on the comment, any idea when that will be complete?
So we're talking about tens of thousands of records in the latest incident, which relates to non-Wales residents. So to that end, we are confident that the notifications will have been dealt with by England predominantly. What we're trying to ascertain is whether any of those were cases that we should have been handling in the first instance because they were either in Wales for whatever reason or in a Welsh hospital. We're confident from the systems that we have that the clinicians looking after anyone in a hospital will have dealt with the situation, and hence the clinical impact is going to be minimal, if any. So for the non-Welsh residents, I think the England system will have to make those up. In terms of timescales, because of the size of the task, clearly the team is also responding to Excise Pegasus, and we'll need to understand what the revised timescales might be in relation to that. But I can find out if that would be helpful.
She's trying to get a sense of whether it's a month, 3 months, 6 months, a year, 2 years. She's trying to get some kind of quantum as to what we're looking at, so we know that that's close to having.
Yeah, I think we're talking months. So I think before the end of the year, we will reach a conclusion on this stage.
That calendar year. Just.
Yeah, just to clarify what Mem was saying, that the results would have been given back to the requesting clinician. So the requesting clinician would still have got that result. It's not as if the result wasn't passed forward and would have expected that requesting clinician would be treating the patient appropriately. So it's not a distribution of results issue. It should we have followed them up as a result of that. So it's which is reassuring to a point, because a clinician would act on it. It's just double checking that whether we haven't missed anything.
Yeah.
That's our role. So it's at least the result would have been distributed to the clinician. So that's reassuring to it.
Complexity is, whilst that is true, the majority of the results we're talking over on this period was related to COVID, because many of those COVID tests were taken by clinicians as such. So there's no requesting clinician, but because of the heightened awareness and the systems and processes in place to manage COVID cases, we're confident that those will have been picked up by those processes.
That's just, I suppose the concern is if we are still reviewing it, then we still have a risk in there. It's just understanding the timescale until we're confident about understanding that risk. The rest is the clarifications help.
I was just going to ask slightly related to that as well. I'm assuming that whilst there are lots of individual cases that still need to play into the review, there has been some work to understand the key learning of how that went wrong and something being implemented around that before waiting for the outcome of the longer review. Is that fair enough?
Usually the chronology is we undertake the investigation and we identify the learning along the way. And if there is any critical learning that needs to have immediate implementation, we will do that.
Yeah, but we wouldn't want to continue an error. So it's stopping the error.
So I think the first control measure to stop this occurring is, first of all, awareness that that list exists. So the long story is that because we've got UK-wide reference laboratories, what we didn't want was to manage the non-Wales results from that reference laboratory. But somehow the technical implementation of that meant that all non-Wales residents' results were then ported into this hidden list. So it wasn't actively managed. So now that we know it exists, we can actively.
Yeah, thank you. Sorry, Angela.
Vertical was the governance accountability section. The detailed finance report is there, and hopefully board can take assurance from the very detail that's set out. Just to add some context, as at month 5, we have a small revenue underspend that we are now entering sort of the part mid-year part. So we'll have our month 6 position by the end of next week. So the month's just by. And following that, we will be holding our mid-year performance reviews. And alongside that, we will be holding very detailed financial discussions with each of the directors to run through the financial performance and also the financial forecasts to ensure that we are funding our year-end break-even position as per our plan. And within the report, you'll see reference to the Welsh Risk Pool contribution increase. We've managed to cover that significant increase for us, but we've managed that through some slippage that we had on our investments and our cost pressure slippage. If you recall that the Welsh Risk Pool contributions were set at the planning stage, but they've increased. And we do have a detailed report, Tracy, that we can share with board as well in terms of some of the background as to how that's materialised. But the rest of the report, as I say, provides a lot of detail. Section 3 sets out our capital position. We've gone into a lot of detail there around our discretionary and strategic. And there's an update in there on the balance sheet, which is in a really healthy position. So hopefully board can take assurance from the finance update there. So happy to take questions.
Yeah, I think the Welsh risk pool situation is disappointing. This has emerged to be a significant increase that every NHS organisation is now going to have to pay. Shared Services coordinates Welsh risk pool, and actually, they play a key role for us as NHS Wales in the work that they do. But this came out as an in-year substantial increase that nobody was aware about. So we're talking about some organisations needing to pay millions extra within a very cost prohibitive environment. So at this point in time, we're not quite sure how much ours is going to be. And for an organisation our size, that is quite significant. So, you know, we are disappointed about the situation. To be honest, if you're forewarned the year before that this is likely to come down, these are scheduled legal processes, accepting that sometimes they become much higher than originally anticipated. It's you know, if it ends up as 370,000 pounds, that's money that we would be using to bolster some of the cost pressures that we've got in other parts of the organisation, like health protection and screening. So it is a disappointing situation. At least we're not having to find 4 million as other organisations. I'm not sure how they'll do it. So it's, you know, it's a cost pressure for the whole of the NHS.
Any other questions, comments? No, lovely. Okay, well, I think we can definitely take assurance from the integrated performance report and the month 5 finance report. So thank you very much.
We've only done 1 second, sorry. So
Oh, yeah, sorry, yeah. Sorry.
So if you move on to section 2, which is service delivery, in the pack, that is 117 to 133. And the 2 areas that we've drawn out in the cover paper are around breast screening assessment weights within 3 weeks and the bowel screening and colonoscopy within 4 weeks. So if I turn to Meng to provide the context on those.
Yeah, thank you. So board will be familiar with the seemingly intractable performance targets on both of those indicators. So first of all, Breast Test Wales assessment invitations is expected at 3 weeks following the mammogram being taken. And the steps in that are the mammogram needs to be read, and it also then needs to be assessed in the clinic. And so the clock starts when the mammogram is taken. And some of those delays are in the reading of it. So there are some expert workforce shortages, particularly in North Wales, but we've used technology to provide mutual aid support so that radiologists and consultant radiographers in the south can help with the reading of the mammograms generated in the north. That's really helped with some of those weights, and that's within our control. What's emerging is that particularly in the North Wales area, is that there is a shortage in surgical capacity, and it's something that I've escalated to the health board and had direct conversations with the medical director and their team about planning for surgical input into the assessment review clinics. Our expectation is that it would be great to have that surgical input, but it's not necessary. So at times we have had radiology-led clinics, which means that we can run those clinics efficiently, and we do that in the south of the patch. But in North Wales, in one of the units, the consultant surgeons inputting into that require them to be present. So at times when we've had absence either through sickness or leave, we've really struggled to hold those clinics. We are having ongoing discussions with them to implement the radiology-led clinics, but we have not been successful yet to get that accepted as part of the pathway. A new medical director is starting in Betsy University Health Board next Monday. So the plan is to reinvigorate that with the new leadership. And it's something that we will potentially need to escalate. Because if this is accepted practice elsewhere in the UK for radiology-led clinics, any referrals arising from that needs to have a pathway, because that has to be a suspected cancer. So someone's coming through the reading as a suspected cancer needs to be treated following the assessment clinic. So that's affected our figures on an ongoing basis. So I'm happy to pause there to take any questions on Breast Test Wales. And we have a substantive item on the review later on, which will help also identify other areas of potential improvement around that pathway.
Thanks, May. Do I understand from what you said that different health boards have different clinical standards and pathways, so that in some, they say you could be a surgeon, place be a radiologist?
The standards are set by us with reference to the UK National Screening Committee. And I think what one unit in North Wales is doing is applying the standards very rigorously without the flexibility of accommodating radiology-led clinics, which is within our standards as an accepted practice.
But presumably we're within the sort of Migrate Foods overarching UK standards.
Yes, so England,
and in England, there's flexibility, or it's usually radiologists or
so in England, they are radiology-led clinics.
And you say there's a new medical director coming in and have a conversation with. And of urgency, I would suggest.
It is. And she's starting on Monday. We're sending a letter on Tuesday.
And he's bringing on to.
What about other things that they're sticking to old guidelines?
Yeah, I hate to drive it through.
Some of this.
No, I just wanted to
So
be absolutely clear, we're behind the pace up there because of decisions by clinical staff and of the past.
some of this is about leadership and management of the demand in Betsy Health. So that's something that we haven't got no control over.
No, I accept that. It's just the pressure we need to bring to bear against this.
The reality is that symptomatic referrals are seen sooner than those referrals from screening pathway.
No, sorry, that's not good standard.
So then turning to bowel screening, the indicator there is about the waiting time for index colonoscopy. I think there's a lag in reporting the August data, but we know from recent trends that is improving. And I think this follows the escalation process that we put in, and Tracy led conversations with each health board, chief executive and their team on the mitigations in place to improve the position. And that has improved over the last 2 or 3 months. We have really valued those conversations, and there has been systematic learning about how we can improve the situation across the pathway. And some of that's within our control in Public Health Wales. So what we've done is summarise the learning into a report, which we'll present to the leadership team, NHS in Wales, but also share the findings back to individual health boards about specific local learning and actions to be taken to improve the situation. But I'm confident that through that process of escalation, this will continue to improve over time. But ultimately, this relies on colonoscopist capacity to undertake these procedures. Again, I'm happy to take any questions.
Any questions?
Well, can I just ask about maybe, is it just doctors doing colonoscopies, or is it extending to a wider range? And
That's been the recurrent conversation with every health board. It's like being, 5 years behind compared to other countries about diversifying a clinically governed, multi-professional group of colonoscopists. So yeah, I think we've got some interesting power balances in Wales, I would say. But it was a for some health boards, which I think there was a bit of a light bulb moment, as we were saying, that actually if you diversify and you've got people who are doing this as a sort of JAG accredited approach, and then that also takes the pressure off the symptomatic as well as the screening. And could make it life a lot easier. But also one of our learning is that it takes a long time to accredit somebody. And whilst we would not want to reduce the standard of accreditation, where we can expedite that, then that's something that we can look at. But that diversified multi-professional group, and I dare say it's not just about this conversational.
I was even if it's where
there are other elements across Wales.
And it's a nice list of recommendations for local teams to consider,
Yes.
especially where they haven't got any non-medical.
I was thinking of the whole of the medical or the healthcare workforce set of issues. Diversification has to be.
And HRW has actually put aside roles, but people will get jobs at the end of it. So, there's a system conversation, and we're going to the leadership board in October. And so it'll be a good conversation to feed all that back.
Yeah, I just wonder as an organisation should be pushing back on the national endoscopy programme, because there was a lot of investment that went into that 4 or 5 years ago in NHS P&I planned care, and where there was a work stream within that around upskilling non-medical workforce.
I'm not aware of anything that came out of that.
An awful lot of money tied up in that programme, still it's gone very quiet.
I don't think they're meeting as such anymore. I used to attend them. I used to get invited, and I saw a reality check on the demand and capacity management, and then it went really quiet because it was huge.
Their new programme lead is then extended to practitioner. So, there's an opportunity there to raise that again.
So if we move on to section 3, section 3 is pages 135 to 146 of the pack. This is on our strategy delivery. So there's a section on each priority which gives you a very clear update on the delivery status of each, along with a summary overview narrative as well to update on the progress being made. So I wasn't going to go through each one, but happy, and each exec director would be happy to take any.
Will be.
Yeah, will be. I'm sure. Happy to take any questions on any of the information in that section.
I mean, it's more of an observation for reflection rather than necessarily answering now. But I noticed, we've got a living of the amber. Seems to be getting a lot more colour in the chart, and the reasons down are about capacity and when we set out this really clear set of questions about your confidence that you had the capacity in place to deliver this, because we didn't want to be having a conversation later in the year, and we're just on the cusp of halfway through the year, and we're seeing capacity issues come up. So it's reflecting back that we had a very clear conversation when we set this plan out about being confident that you had the capacity to deliver it, because that's something we should be planning and have planned for. So I put the challenge back that if that is the real reason down there, and some of them are getting short-term capacity, but things like secondments, that's a planning issue in my head. So I put that as a challenge back to the team about, is that because it's something I'm planning, are there undue circumstances here? Is that, or another question, is that the real rationale for why we've got living amber coming up now? So it just feels that either that's, wow, there's an answer, or have we got enough understanding of why we've got all those ambers?
And it's spread across each of the priorities, so that's something we probably need to look at.
Yeah, I mean, it's 181 greens and 11 ambers, so 6 months in, there will be a little bit of moving around. The important thing is they're landed by the end of the year.
Yes.
And well, you've got it here as well. We have every month we have the request for variation where any action moves. And where it goes into the next year, I will have a, unless it's an obvious reason, I'll have an issue about it's rolling in. So we don't include it to have a conversation, but most of them are about months of moving months. Some are around, as we've have said before, we put an interdependence colour on this. So where we've got actions on interdependencies that may be subject to Welsh Government approval on something, which pushes it out because there's a delay in it, or implementation of something like the health assessment rates, when there may be a delay. So some of them are more than understandable. I think and I wouldn't be worried about those. I think it's how do we, maybe Andrew and I can follow up, how do we identify the ones that have really are significantly going to slip, and just capacity may be the reason, but it may not be. So there are a couple of aspects of some of these actions, but the minority, where they are really quite niche, and so if somebody goes off, we lose that. So we could maybe do a bit of a in-year, mid-year, bit of a deep dive on the ambers and reds at this point, and maybe bring them back. So it's a fair comp. We had a lot of discussions at execs to say, have we got capacity? Ian led a significant piece of work going through all of it around digital data. And so we cut some stuff out and we shifted the timeline on the capacity to deliver. So this should be a plan, unless there's stuff that comes in year, like gambling, it's coming in year that we weren't anticipating quite to the pressure, then we should be delivering it. So if we take that away, Nick, and it's a fair challenge, and maybe do focus on the ambers and reds a bit, and do a little bit of a deep dive for the next board meeting. That would be great.
Thank you. I mean, that is exactly what I'd like to, and I totally take the point actually about, wow, what a lot of grief, and it is good. But it's the reasons for the other bits, and if we can get it to the ones which are absolutely the causes you've described, actually we get much more done. Because we know a lot of work went into it, and we want that work not to reflect in the outcome that we expect. Yeah, thank you.
And then on to the last section, which is the in section 4, which is the outcome measurement section.
I know that, I think Tamsin's similar question earlier. Sorry, I think the outcomes kind of got we provided the latest updates. There weren't huge numbers of updates, so there's not much deep dive in there. I've updated you already on smoking prevalence, which is the only change since then. Overarching, though, most of them are not really moving in the right direction. But Tracy's challenge to me now is we've still got work to embed this into the system. And how does that link back to the priorities which we just talked about? So that actually, if what we're doing isn't having the size and scale of impact we need on the outcomes, then how does that get embedded and change what we do? And that is very much work we knew we'd have to do during this year as we develop the system.
Can I just say, sorry, I didn't pick up the inequality slide, but it's almost on the outcome slide. And I, because I had time, I went down some of the little links on the latest data in the Public Health Observatory. And it was sort of that map that's there, slide 51 and 56, which shows that Wrexham is one of the poorest areas in the UK, and the growing healthy life expectancy gap. And the figures in the data, just for cancer, for example, growing rates of inequality, as well as increasing numbers of cases. And it's just quite salutary to see that data sitting there at the moment, given everything else that's going on around us. So I think just wanted to comment on that, say I found that worrying. And then you go on to the outcomes data, and you look at the data in the Public Health Observatory, and it's a huge challenge. It goes back to Jim's point about we're just about holding the floodgates back. It's going to get worse. And it's how we then use that message to engage people in the broader sector who can help us. I know Selina's team are doing a lot of work on this, but it just is pretty startling that you see it written like it is there. And that little map that shows Wrexham in dark red is the most depressing thing, I think.
And this goes back decades.
Oh, it's decades. It's not just yesterday. It is decades.
And there's a real. I'm Welsh, and I'm through and through. But I think there's a societal cultural narrative here of expecting less than people deserve. So you know, we see it through the lens of different conditions. It's like diabetes and some of our communities and families will say, you know, Gran's got sugar. And it's assumed that everybody's generationally going to have sugar and diabetes. So it's the third sector is really key. And I don't think we've tapped into that enough yet. I mean, we're trying, but people aren't, it's not just our messages, it's how we mobilise a nation in a way. But there's a huge amount going on by this organisation. It's just starting to see the rubber hitting the tarmac and of kind of an entrenched challenge is tough. But if we don't start getting on top of it and we don't start preventing the deteriorating NCDs and cancer for the future, and we don't shift to prevention, it's just going to get worse.
Absolutely.
Yeah, just very briefly. Sorry, Samina, as our National Director of Policy and International. Sean, I'm really pleased you picked up on that graph. It's part of a sort of work programme that we're doing on health inequalities. And this was done by one of Ian's team. She's done a fab job. What she's done is sort of looked at Health Foundation data, looked at premature mortality. And there's something really interesting in that, that even if you take into account socioeconomic status, education, migration, ethnicity, there's still a difference and we don't quite understand. So I think this kind of helps us to really delve deep and, you know, and try and work out what on earth is happening, because it's not just.
No, I think that's what the Health Foundation report brings out very clearly. Can't just say it's an immigration issue or an obvious issue. It's much more fundamental, and it does pose a big challenge. It's a very interesting report, the Health Foundation.
Ian, did you indicate to come back in?
No, I didn't, sorry.
I think I'd like to go back to the point Tracy made, because for me, I think this is the killer. If we start from the position that the people of Wales deserve the very best health and deserve the very best healthcare, I mean, never mind the other 3 nations, you know, I'm not biased. There is a series of issues, as we've discovered if you're sitting in rooms with service users, and one of the reasons for one of our reds is because we've decided to extend the amount of time we spend with service users listening and learning, because we thought that was important, and we will make the time up in the rest of the programme, is that there is an issue, Tracy's absolutely right, about cultural expectation of less, and there is an issue of saying, no, you have a right to the best. So I think our role of galvanising the system, pushing into the system, identifying those things where we can change, like the CBD plan. If we got 71,000 people in Wales with hypertension, we sorted that out, that's 1,000 heart attacks and strokes gone. So there is huge amounts to do. I think we do have to galvanise the third sector and work with them. I think this is something about firing on all cylinders in a very targeted way for the next 5 to 10 years. But I'm pretty determined. If anybody can make a difference to it, we can. I think we are up against it, but you know, hey,
That's our job.
That's our job. Yeah,
exactly.
And so I think the more data we get, but it strikes me there is a cultural issue about health expectations in Wales that is similar to the health expectation I grew up in a mining village in Scotland, you know, but is actually more entrenched.
Sorry, so we done it. Why not? You know, it's what we're here for.
I mean, just to come back on the immunisation changes in the same page, they're depressing too, because that's early in life. You know, we have got a huge challenge about getting on top of this, and I do think that the current macro political climate is affecting this, particularly immunisation, and therefore knocks back into other areas of health and taking empowerment and feeling you're in charge of your health.
Okay, lovely, thank you.
Challenge.
Well, we can belatedly take assurance now. I've got ahead of myself, so sorry. But with all that, we've got this in books accounts, challenging as it is.
We're all looking at you, Jim.
We are not going to give in.
Don't give in.
Excellent, thank you. We'll say if we can come back at 35 13:35, something like that. Is that okay with everyone? Sorry, thank you.
Yeah, thank you, Claire.
We're now on Breast Test Wales review framework. So, Frank, can I hand over to you to take us through?
Oh dear. So this is a paper to outline the intention to commission a review of the Breast Test Wales programme. I think the context of this is to note the recent events in relation to a series of events, including the IRMA inspection, the implementation of the PLACS process, and also the Gateway review that has highlighted several areas where there's potential to improve performance and business delivery in the programme. So recognizing this, what we and I felt was necessary was to undertake a systematic review of the service provision so that we can provide assurance that we are optimizing the delivery of the programme so that we are delivering an efficient and effective service. And this is in line with the duty of quality and the domains of quality, using the STEEP framework as the basis for our review. And the objectives are to undertake a comprehensive review to look at the performance of the breast screening programme pathway, looking at the end-to-end processes, make sure that there's a deep understanding of the factors that are affecting quality. And the board will be familiar with some of the factors that have been surfaced around the lack of specialist clinical workforce to deliver the pathway, because the Breast Test Wales programme is heavily dependent in a different way to all the other programmes on the clinical input. We also want to review and strengthen the governance structures across the entire screening pathway for the programme, but the ambition is that the learning that we identify will have relevance to the other screening programmes that we run as well. We also want to rigorously assess the compliance with our national minimum standards to identify what areas of variance there are and support professionals in addressing the gaps and enhancing the quality and consistency of service delivery. We want to develop a prioritised service improvement plan based on the evidence derived from these reviews to systematically gather and evaluate and build expertise in best practice and to facilitate the sharing of insights with other screening programs and with the team itself. And to date, we have liaised and really valued the feedback from other execs to framing this review, and we have communicated this now to the program team so that people working in Breast Test Wales are aware of this review and the detail of this, and they welcome the opportunity for ongoing quality improvement, which is really important because we do want the program to feel the ownership and therefore contribute to the review in the most productive and constructive way. So the review leadership team will be led by Tom Fowler, my deputy, and Michelle, who's the deputy assistant director for operations. And I think her input is invaluable in that we need to develop a service delivery model that incorporates the business functions and the elements as much as the technical elements. And that may be an area that will have a bearing on the other screening programs and how they're delivered. So just to confirm that we have communicated this now to the team. We have convened the senior review team members from across the organisation, and I'm grateful to exec directors for allowing their staff to engage in this and contribute to the review, because their expertise and their experience will be really, really helpful to ensure that we have a degree of externality, that this is not just an internal directorate view, that we also have that rigour in terms of the analysis and the report that's going to be written up at the end of this. There will be ongoing monthly update reports to the executive team, and that will allow us to have a discussion about the ongoing progress of the review and identify and escalate any concerns during that time. We anticipate this will take probably 3 to 4 months to its conclusion because of the scale of the review that's being undertaken. So board is asked to note the direction of travel and take assurance that this is with the intention of improving the quality of the service that we deliver, and also consider and note the allocation of resources, take assurance of the framework that's proposed for the review. Thank you.
Thanks. I think, Meng, as I said to you, I was wondering about how you were going to get the users' input, women, the user service, and also partners, so primary care or clinicians.
That's a really valid point, and if we are aligning it to the STEEP indicators, then the people-centered focus will allow us to review information we receive on an ongoing basis, whether formally through the compliments and complaints process, the incident notes. But I think there is some elements there that we probably could explore further.
I was
around
thinking the user input
engagement.
is probably like contextualised service as well, maybe add some depth.
So let me take that back to the team about how we incorporate.
I mean, you've got end to end. I know you're focusing on what we're delivering, but it either end is important in you know, how it all fits in the future.
Sorry.
Thanks, Chair. I certainly support that strengthening the role of the patient in the review, because it is difficult to be about that patient. I'm sure they could provide some invaluable insight actually into the process that probably we don't think of as a provider. I welcome the proposed review, particularly the fact that it's going to be independent within the organisation, but I'm mindful that it's a review by the organisation, and I wanted to ask how we are going to maximise the use of good or best practice internationally. I think that's really important that we look outwards and see what works well. It might be there's aspects of the service that we can be proud of, but I'd like the reassurance about that and how that will be, if possible, a very strong feature of this review.
So there is an ongoing discussion across all screening programs about how do we ensure there's external quality assurance. So in England, I was very familiar with the clear blue water between the QA elements and the delivery elements. And there was a resource entity. Now, in Wales, there isn't such a resource entity. We have external quality assurance of the services we commission, but ironically, we don't have external quality assurance of the services we deliver. So that's a system gap, and it's a gap that I've identified and am in discussion with Welsh Government about how we plug that gap. In the meantime, we have initiated discussions with other programs, so in the other nations, to ask whether they would be interested in a quid pro quo exchange of external quality assurance where there's mutual benefit. So one early indication is that Scotland is eager to have a system developed so that we provide peer-to-peer support, but also an element of external quality assurance. But I think that is a parallel development to this, which is a pressing need to establish a review for breast test Wales. But there is ongoing work to look at the other programs and external quality assurance.
Very much welcome that chair, but that's the home nations. I was thinking about internationally as well, about other programs and how we can learn from and share, if that is possible, good or best practice from around the world, because I'm assuming these programs are international programs, and there's a huge amount of commonality. I'm assuming, but I might be wrong to make that assumption. And I'd be interested in that, because I wouldn't want us to be looking just across the UK, because sometimes that, sometimes we lead the world, sometimes we certainly don't lead the world, and I don't know how we compare with the rest of the world, and I would want us to do that if we can. And I know certainly that's something as an organisation we pride ourselves on, isn't it? Is having that international perspective.
So international benchmarking is a really interesting point, because like our vaccination programs, they vary from country. Standards will vary as well from country to country, and the context and the delivery mechanisms will vary. So we might not be comparing apples and apples. So I think there is a challenge there, but that doesn't stop us looking. And I think the way to do it is probably through the UK National Screening Committee, right, to surface that debate actually about international.
Thanks so much, Ryan. Thanks so much, Chair.
Yeah, no, it's just an offer of help. We've got Monica who and Griff who do the user research, and happy to help offer them to get that user insight into the programme.
Oh, that's really welcome. I mean, when you look at the detail under user experience, there is an element already built into the current review framework. It's how they then are engaged in the senior review team, I think, is probably key to that. So we'll be gathering information from users, but Monica's expertise and Sinead's and Hades as well is going to be key to this. So thank you for that.
Sorry. I think it's worth us linking in with WHO as well. And as Meg says, we're quite unusual in that we have a national role in delivering and commissioning. So in England, it's it's devolved to the NHS with the QA function of a national body. So the interest that the organisation of screening is very different. In Ireland, it's different again. Interestingly, quite a lot of countries have come to us for advice, but I think and maybe a bit of an international horizon scanning activity and looking at what models exist for screening, population screening in different countries, and where the performance is good, and that may be helpful as well. Helpful report to feed into the UK screening committee as well, but maybe that would be useful. May not be timely for the report, but we could certainly email WHO colleagues and just see if they're aware of whether it's, you know, some of the higher end screening performance. It is apples and apples, and even Ravens and Granny Smiths, and then you kind of diversify a bit. But we should be looking at different, because the principle of it should be the same. It's just the delivery will be different. Not a thought. Question.
So, I mean, my question was actually in a very similar vein, but normally doing a review, I would expect to see someone on there who's bringing the expertise of that service. I wasn't objectively bringing that. So rather than the more formality as described, which I totally support of how we work with other nations potentially, and I think internationally to do it, is there not an advantage in having someone there from another service? I'm using the language liberally, in other words, there's no less formality, who can provide expert insights to how the service runs.
You mean like someone from Scotland?
Could be someone from Scotland, yeah, just someone who understands the services and can help the review team kind of see, not necessarily just their model, but some of the challenges that these services all face and how they generally work. Because otherwise, I think there's always a risk that you end up pushing the wrong buttons as well as the right buttons. I mean, a lot of it is around governance and process, which I think absolutely, I think this is great. I welcome it, first of all. I think it's absolutely the right thing to do, fully support it. Just when I've seen these elsewhere, you normally have some trusted partner from elsewhere who brings the expertise of that service, so that you know you're not going to make an obvious faux pas of the service, therefore will buy into the point, I suppose is how I say it politely. That makes sense.
It makes complete sense, and we'll look into the options of that, and maybe that would be, you know, the starting point of having a discussion about what does an external quality assurance framework look like. And it may well-
kind of distance the two, or having a review is having someone who's
You know,
trained
so-
risk support, who's part of the team and is helping you. And they might just be putting in the team, but they're helping you keep a sense of the balance. But I fully support the other piece of work is how do you get into that kind of more formal
Yeah.
QA, which gives us a much better assurance process every X year, whatever it might be, and we reciprocate. Well, totally support, but I think they're two separate things. So when you do a review like this,
It's the
it's
technical
hugely
knowledge.
valuable to have someone who is an expert in that service to help you do it. Observation, one to consider.
Yeah, we'll look into the options to do that.
Brilliant. Thanks, Ray. So I think just to try and sum up a little if I can, we're saying that we all hugely welcome the paper and the reports as it currently stands, but that you're going to go back and do a bit of work with the team and maybe with Ian around building in that user experience along the whole of the pathway. Something about potentially a trusted person that knows the service to come along and do it, and then the wider part with who and international partners around benchmarking. That's a amazing package. So thank you ever so much for your time with that as well. Moving on then, we have got committees of the board report. So first one to me. So QSIC had a meeting where we looked at the annual quality report, which is presented later in this agenda. So that's my update, very brief. I know, Sean, you've met as well. Yeah.
I wasn't at QSIC now, but do you want to move on to Craig?
Yes, sorry.
We met on Tuesday, so relatively fresh in my mind. And we had a deep dive into primary care, and was really impressed by the focus within the Directorate on Research and Evaluation as personified by Pert. And she held it all together beautifully. Coming out of that, of course, was that whole issue of need for primary care data. I flag it up yet again. I mean, it's just something that comes up all the time. It's very difficult to do work. Also, the strength of the dental public health research came out from the meeting. We looked at progress and were assured about progress on the data program, and we looked at mental health, an update on mental health, and an update on genomics. And from the genomics update, we recommended that that the work that's been ongoing should be to go out for consultation. It's about genomics plan for the future. It's linked in very heavily to other work in Welsh Government, so it's not just us, but the element that is us needs to go out for review, consultation, and come back in to be finalised. And we'll see it again. We said we didn't need to see it to be as finalised at the committee, but just to note that our recommendation was it should be reviewed. I think that was everything. Ian, is that right?
Yeah, and we also reviewed the digital and data delivery as well.
We did, touched on AI.
Yeah, thanks.
Oh, and international. Got through a lot. Congratulations again on the international WHO.
The other bit, just on the primary care data, I did take an action, which is to formally write to Welsh Government about the lack of primary care data and the impact that's having on our abilities.
Any questions on that? Or on my extensive report before we get on? Oh, lovely. Okay, thank you, everybody, and both for the committees. So now seamlessly on to Claire to talk about the Duty of Quality Annual Report and do it some justice, because I will say, having been very brief, it is an amazing piece of work, and you know, it really spans everything that we do across the organisation. We had a really detailed conversation about it in QSIC, and hopefully we will all agree. So that was everything.
So thank you for the opportunity to present. We've got two papers in the pack today. One is the cover report, which describes our approach and the reason that we write this report, and the second one is the draft report itself. So we pull this together. It's the second year that we've done this, and it's the responsibility under the Act that we have to represent the work that we have done from an improvement perspective under the duty of quality, under STEEP, and the supporting enabling domains, and also to identify those areas where we need to improve or they plan to improve. So as last year, we tried to mature this work through engagement across the directorates and the divisions, and we've used our quality oversight group to focus those discussions, and loads of really great examples coming in across all of the organisation, and it's really good to see the work and to put it together so that everyone can speak together. We've got 50 stories within the pack that demonstrate the breadth of the work across each directorate that is represented, and under each of the areas of STEEP. So in terms of the report, we have been through various discussions with directorates to refine the language, and also to make sure that we're demonstrating the improvement journey. And then this has obviously been to QSIC for approval, and is coming here today for approval, and subject to that, it will go forward to the professional designers. I've just got a snapshot which Elizabeth has shared to show you what it's going to look like. Not going to be that small. So hopefully we'll really bring it to life. It's a reminder, this is for our population to read, so it's not for us. So we have to be really clear about our language while celebrating some of the really technical stuff that we do as an organisation. So going forward, we're going to review how we do this and to see whether we can get more of a web-based approach, so there's a little bit more interactive. And but now we're in the groove of what we need to share. It's about how we use that message to share it. So I have to thank everybody who's contributed to this, particularly the members of the QOG. Angela and Angela's team under Wayne Jepson's leadership, but also a lady called Hilary Wildersbin, who we commissioned to do some work with us this year that helped us write this report, which gave us a little bit of independence in terms of why we're using this language. And I think she's done a fantastic job, so I will write to her on behalf of the board to thank her for the work.
Or do we got any questions or Claire, or any comments? No? Oh,
No, I'm the only comment I have just visually expressed on, I've seen this, it's a great report, and, thank you, just echo Claire's thanks. And it's a long report. But this year we just wanted to showcase the breadth of stuff, it kind of isn't about do a short report, it's about give everybody their plug-in so it can be, demonstrated. So I think it's a really great piece of work, and thank you to the team, you and the team for coordinating. I'm sharing because I've got an instant response to that visual, which is a great visual. Just let's get the kind of visual disability assessment on it, because it could be very busy.
Yeah.
For someone reading with some visual impairment. So that would be the only comment I would make. So it's just run it through the kind of disability.
Company.
Yeah. Great.
yeah, thanks Claire. Yeah, and if you could pass on our thanks to everybody, because it is an amazing bit of work. That's lovely. Thank you very much. So if we move on to items for approval, and we'll start with the minutes and action log from the July board meeting. So if we start with any comments and approval for the minutes. That then. And then hand to Paul on the action log.
Thank you, Chair. Paul Vasey, Board Secretary. So there's an item of risk on the action log, and this relates to the systematic review of screening services. It was scheduled for board today, but it's been rescheduled for November with the update on the breast as well as framework review being provided today in its place. So that's on track. There's a request for a revised target date to November for that. One action is then on track for November board, which relates to healthy life expectancy data. And then there's 3 completed items there for closure.
So everyone can take to note the action log and approve the actions identified for closing or updating. Yes, lovely. Okay, so if we then go on to the NHS Performance and Improvement Hosting Agreement, and I think it's back to you, Paul.
Yes, Chair. I think back to me. This is the former NHS executive, now the NHS Wales Performance and Improvement. We are obviously the host organisation for NHS P&I. The hosting agreement came before the board in draft back in March this year for the hosting arrangements for 25-26. At that time, some amendments were required to the agreement, but also the hosting fee remained to be approved and agreed. Since that time, we've had the Ministerial Advisory Group, and the NHS Executive has changed its name, and there's been other functional changes, including the proposal to appoint a managing director for the NHS Wales P&I. That process is currently underway. So it gave us an opportunity to re-update the hosting agreement and bring it back to the board today to reflect those additional changes as well. As well as having the managing director in place for the P&I, there's also changes in terms of the role of the Deputy Chief Executive of NHS Wales, and that function shifting over to the Director General, who is the Chief Executive of NHS Wales. So those are the main changes. The document as it stands is now capable of agreement, and I would ask the board to approve this entering into that agreement. In terms of the hosting fee, we're still not quite over the line, but we're much closer. The board will remember that we were restricted by the value of one band 7 in the people and OD function. There's going to be, and the reality is that within the P&I, there's going to be a need for much more input from people and OD over and above what was expected in the hosting arrangements for the balance of this financial year, maybe even into next. And Neil is in discussions with Welsh Government colleagues around how we approach that with confidence to give to the board today that we will reach agreement to make sure we're adequately resourced. So in approving this hosting agreement for today, the ask would be that the approval of the final agreement of the hosting fee is delegated down to the executive team, just so we can make those final bits and bobs approvals to get that into a position where we are satisfied that we have sufficient resources to deliver this hosting agreement P&I.
Everybody happy? Everyone's expecting to see by then. So we will agree that we will dedicate it down to the record. Risk management policy. So Claire, do again.
So the arithmetic policy is here today for your approval. I had to check with our board secretary why it came here and not the audit committee, but it's not delegated to audit committee, the procedure is. So that's why it's here for you. It's not been updated since 2021. There has been a delay, and that was really associated with the delay in decision making around Datix Cloud. We know what that decision is now, even though we haven't got a solution, and therefore we've proceeded to update the policy. It's been through all of the usual engagement and sign off across the organisation, and really it now reflects our risk maturity, I think, and covers off a number of the changes around appetite, but also tidies up some of the housekeeping around rules and responsibilities. It reflects some of the changes that we've got in there now around training, and simplifies some of the cross-organisational risk registers that we have. It also strengthens the use of Datix, which we know is really the driver for how we manage risk across the organisation. So those are really the key changes since the last update report, since the last policy, sorry, and it is accompanied today by new QIA as well.
Thank you for the work. Any questions, Nick?
I mean, it's a minor observation. Apologies for it, it's quite important, I think. On page 3, when you mention the title of the key people, you've got interim executive director of operations and finance. I don't think you should have the word interim in a policy, because it's fulfilled by the person who's filling the role.
How would you like me to reflect that, given we currently have an interim?
I mean, I think it'll, because the job title also will change. So I think that it's whether or not the board delegates the change of that. It's a bit, because one way or other, it's going to have to, it will change the next couple of months. Because the title we've got currently, and the title is Ops Finance. The title will become Strategy, Finance, Performance. So, but we can't change that yet because it hasn't come into effect.
And I understand that, but it's the word interim. You can't have the word interim in a policy document.
We can remove it.
You just remove the word.
Yeah.
That's fine.
Yeah, we think it happens to be Andrew.
I know.
Yeah.
I'm just saying.
There was a fence.
It's just a policy process, and that's why I said, and I apologise, it's a real pedant. But it's quite important.
I've got a hidden point of The next title is National Director of Health Protection and Screening Services rather than Screening and Health Protection Services. So sorry, I'm with Nick on the.
Sorry, but what is it?
Any further comments from anyone? This is the pen. Okay, so are we happy to approve, subject to that amendment and Nick's and the delegation of the change when the job title becomes permanent? Lovely. Okay, amazing. Thank you. 5.4 then, ratification of chair's action and affixing the common seal, and Paul again.
Thank you, Chair. So there have been no chair's actions since the last board meeting, so none are noted in the report. There has been one use of the common seal, which was to seal the lease for number 3 Parkdale in Carmarthen, and the board remember that the application of the seal was approved at the last meeting, and this report now confirms that it's been done. Other than that, it's just assurance required today that those actions have been properly undertaken.
Comments from anyone? No, in that case, I think we're happy to ratify the approved use of the common seal and note the change, note the declared action. Lovely. So we're just on items to note now. Just saying that. Has anybody got any comments that said on any of the things that we've got? Oh. Any other business? No. Yes. So date of the next meeting then is the 30th of November 2025. As we close the meeting, thank you everybody for your tolerance and support.
Excellent sharing. That's rare. Excellent sharing.